headache disorder in children and adolescents. The diagnosis of primary headache in children and adolescents rely heavily on the good clinical assessment and the clinical history, as there are no diagnostic biomarkers or confirmatory tests to exclude or to confirm the diagnosis of primary headache disorders. Also, the International Classification of Headache Disorders relies heavily on information collected through clinical assessment in fulfilling the criteria for the diagnosis of different types of headaches. Also, the clinical history and the clinical assessment are able to identify patients with red flags and to identify patients who will require further investigations. For a successful consultation, it is very important that it is carried out in a relaxed atmosphere. There is ample time given to the child and to the family to express themselves, and also for the child to tell his or her own story using his or her own words. It is very important to give open questions if necessary, but also to allow the parents the chance to contribute to the consultation by either filling the gaps or adding missing information. The child can be interviewed with the parents together, but there are occasions when you need to interview the child on his or her own. As part of the clinical assessment, we need to take history of the general health of the child and look for present and past illnesses, any medications the child is using, whether it is a prescription or over the counter, and any other associated conditions or comorbidities. We need also to inquire about the child's lifestyle, including regularity of his or her meals, the routine of activities, exercise, and also her or his sleep routine. We may also ask about the time they spend on electronic screens and if they are using any other substances. We need to explore the psychological aspect of the child's life and to ask questions regarding any anxieties, worries, or mood changes. We need to ask about the emotional status and the family setup and any other social implications which may contribute to the illness, whether it is at home or at school. When we ask about the headache disorder itself, we need to identify the pattern in which the headache appears, and there are several patterns as you can see on this slides. There are occasions when the child presents with the first ever attack of acute headaches. There are occasions when the child presents with recurrent isolated attacks of headaches which are acute and severe, but between attacks the child is completely well and normal. And there are types of headaches where the child have low grade headaches, fluctuates within a small margin and very frequent, but the attacks are predictable and stable over time, and we call it chronic daily headache. And there are occasions when the child has headaches which is chronic but progressive, and the severity and intensity and the frequency of attacks increases over a period of time. We need also to ask about the attack itself, and if it has more than one phase, we need to identify those, especially as we ask questions about migraine attacks. We need to ask about what is the state of health, or whether there are any symptoms before the headache starts, if there is any warning signs or aura symptoms, and we need to ask questions about the headache phase and the recovery phase, and most importantly, we need to ask about state of health during or in the period between attacks. When we ask about the attack itself, we need to know the frequency. We need to know if it is a stable frequency, it is predictable, or there has been a trend in an increasing frequency or decreasing frequency. We also need to identify a pattern of presentations where children will have a spell of high frequency attacks and a spell of low frequency attacks, and we call these as good spells and bad spells, which is not uncommon in the children with chronic headaches. We need also to ask about the duration of each attack, the shortest, the usual, and the longest. And we need to know what is the duration of attack if it is successfully treated, and what is the duration of the attacks if it is untreated or unsuccessfully treated. Before the start of the headaches, the children may identify any trigger factors, and we need to know about that. The common trigger factors in childhood are missing meals, lack of sleep, or a stressful event. But they can also identify other factors such as any certain type of food, or sometimes the effect of a climate. We need to ask about premonitory symptoms, which is about a day or 12 to 24 hours before the onset of the attack. And some children may report times when they feel their mood is low or swings. They may be craving for food, yawning, nauseated, or they might experience excessive fatigue and tiredness. We need to ask about aura symptoms if they are present, and they usually are present about up to 20% of children with migraine. And when we ask about aura, we need the child to describe it him or herself. The most common auras are visual, and they are commonly monochromic and with varying intensity of lights and brightness. It can be associated with moving objects, but it also can be associated with distorted images. The second common type of headaches of aura is the sensory aura. It can be either positive, when the child has positive sensation of pins and needles on one side of the body or both sides, or it is a negative sensory feeling when the child does lose sensation and report numbness on one side of the body or part of the limb. A third type of aura is the motor aura, where the child feels weakness on one side of the body, or it might affect the speech and the child may present with dysarthria or dysphasia. Sometimes the children cannot express their experience with aura by words, and it is important to give them a chance to draw it if that is what they want, and encourage them to do so, because children can express themselves, not only the aura but also the entire attack of migraine, by drawing. And this is an example of a good drawing of a child's aura. Then we ask about the pain itself. We need to know the site of maximum pain. We need to know the quality of the pain, and in this particular question we'd like to hear the child's own description rather than to give him a list of choices to pick one of them. We need to ask about the severity of the pain and how does it progress. Some children starts with mild pain, and pain increases intensity over a period of time. We want to know how long does it take to reach its peak. And the pain intensity can be assessed by the behavior of the child. If the child can carry on normal activities during the headaches, then we call it mild. If the child stops certain activities but can manage others, we call it moderate. And if the child can't do any activities and has to stop and lie in bed, we call it a severe headache or severe pain. We need to ask about other symptoms associated with the headache, and we need to know the order in which they appear, but also the order in which they disappear. These symptoms may include loss of appetite, nausea, vomiting, intolerance to light, noise, or smell, and sometimes change in color. The parents will report the child looks pale or red in the face, or some autonomic features such as redness of the eye, watering of the eye, or dilatation of the pupils. And sometimes the child will report feeling dizzy, and if they do report that, we need to ask them in particular what do they mean and whether they describe unreal sensation of movement, which is typical of vertigo. We need to ask the child about what makes them better, and what are the relieving factors. Quite often they are they include rest, sleep, taking medications, and sometimes vomiting may induce recovery of the attack. Between attacks, most children with primary headaches will return to normal health, but if there are symptoms during or residual symptoms between attacks, such as continued nausea, dizziness, visual disturbances, or gait problems, then we need to think about the possibility of secondary headache. If the child reports different types of headaches, each type of headache should be assessed separately, and a history will be taken for each type of headache. The use of headache diaries can be very useful, not only in confirming the frequency and the duration of attacks and the associated symptoms, but it also can help us in monitoring the progression of the disease and also monitoring the response to treatment. Diaries can also be helpful in identifying different types of headaches at different times. Assessment of the impact of headache on the child is also important, and we can use health quality of life questionnaires or the BEAD-MIDAS assessment scale. Physical examination is also normal in confirming the normality of the patients with the primary headaches. It can reassure children and parents that people are looking and examining and searching for other possibilities, and it helps in identifying red flags if they are present. General examination should include measurement of height, weight, and blood pressure, examination of ENT, musculoskeletal system, and head and neck. Neurological examination should include the assessment of the cranial nerves, optic discs, signs for raised intracranial pressures, and signs of cerebellar dysfunction. Sensory system is not always necessary to be examined, but if we can, that will be helpful. And before planning or management, a positive diagnosis of the type of headache need to be done, and before that can be accomplished, it is very important to make sure that parents are given the opportunity to express their worries or concerns, to explore their expectation from the consultation and their experience and their own experience with headache and their interpretation of the symptoms. I will stop here, as the treatment of headache disorders and other issues will be dealt with in other webinar. Thank you for listening.